Today, I am pleased to welcome Jack Lynch, the president and CEO of Mainline Health, to our Leading for Safety podcast. Since 2005, Jack has been at the helm of one of suburban Philadelphia's most comprehensive healthcare systems, which includes 4 acute care hospitals, a renowned rehabilitation hospital, and an addiction treatment center. Under Jack's leadership, Mainline Health has not only expanded its reach and services, but has also made significant strides in safety, quality, and equity, key areas that have earned the system national recognition. Jack's commitment to fostering a culture of safety and equity is evident in initiatives like the annual Disparities in Care Colloquium, which brings together leaders and the community to address healthcare inequities, and the expansion of behavioral health services. With a strong emphasis on the STEEP domains, safe, timely, effective, efficient, equitable, and patient-centered care, Jack and his team have embedded these principles into the very fabric of Mainline Health. Jack, it's a pleasure to talk with you and great to have you with us today. And I'm excited to dive into the strategies and lessons that have driven Mainline Health's success.
Well, thanks, Mindy. It's thrilling to be on this podcast and really exciting to have you as the moderator and really end up in a dialogue about some of the great things we both had the privilege to lead that have impacted safety, quality, and equity in the communities that we serve. So I look forward to the discussion.
Well, let's get started then. Your approach to patient safety is remarkable in so many ways. How you've integrated health equity into your quality and safety work. Before we dive into the specifics, I'd love to hear your personal journey as a CEO. What inspired your passion for improving quality, safety, and equity? Were there particular experiences in your career that fueled that commitment?
So should I take the whole 20 minutes to describe that? First, Mindy, I would tell you, I don't like the word I. I'm going to use the word I when I talk about what inspired me and what got me started. But from then on, it's about the team. And as you would underscore with your team, we don't get to where we are in delivering the care that we deliver without the team that we have the privilege to lead. So I was blessed with a father that was a physician, an oncologist specifically, and a mother that was an RN. I had the opportunity as a 17-and-a-half-year-old kid to join the Bethesda Chevy Chase Rescue Squad, and I was an EMT for 9 years. Really was enthralled with the logistics and the delivery of pre-hospital care, not really interested in the medicine side. And so when you lay that experience and that development with my Jesuit education, 8 years of high school and college, and justice for all and serving others, healthcare leadership was a natural thing that I had a great deal of interest in. Over time, I learned more and more about the impact healthcare and the impact of quality and safety and now equity have on individuals. And what it comes down to is I really want for others what I want and expect for myself and my family. And so I'm privileged as a white male to receive a level of care that a lot of other people don't receive. And not because I'm a CEO, but because I happen to be a white male. And so that's played into it as I've learned more and more about the issues around equity. But if I go back to the early 90s, when To Err Is Human first came out, we all argued about the numbers were wrong. And after we got over the fact that even the numbers were 50% off, it was still a lot of people being hurt in hospitals. And I think that's when our field, I don't want to call it an industry, that's when our field really made a commitment to address quality. What I'm hopeful is that we'll make the same commitment to address the equity issues. But let me go back to the safety. We started measuring it, we started reporting it, and we started developing action plans. Today, when you and I are leading our institutions, we're informed about bad events that occurred in our institutions. When we started our careers, the C-suite never even knew that these events occurred. And so we've been able to reallocate resources to address where these issues are hurting people. And I think we've made huge progress as a field. In terms of my passion for equity, early on in my career, I read an article about an inequitable care in a major academic center that really focused around ED care and heart care. And the conclusion of the study basically said that the outcome and the care provided were impacted by your race, gender, and ethnicity. And that was really disturbing as a young leader, that based on your zip code, which we didn't talk about that at the time, but race, ethnicity, gender could really determine what your outcome was. When I think about the greatest impact that anybody's had on eliminating disparities of care, what comes to mind first is the American Heart Association's Go Red for Women and all the work that's been done to educate women and care providers about how women present differently. And then I had the privilege to join and ultimately serve as the chair of the Institute for Diversity in Healthcare Management, an AHA organization. And that's where Fred Hobby really connected the dots for me around we need diverse leadership if we're going to address this issue of disparity of care. And so that's kind of what led me to this passion that I have around quality, safety, and equity.
I appreciate that. I think there are a couple of things that you said that I want to highlight. One is healthcare is the ultimate team sport, and it is all about the team, and particularly in areas like quality, safety, and equity. It cannot be just a top-down, we believe in this. It really has to be pervasive throughout the organization. And then finally, you and I both know that over our careers in healthcare, equity, and particularly inequity, was not talked about. We all knew that there were disparities in healthcare, that there were inequities in healthcare. But you would ask people, and they'd say, no difference in my emergency room, until we really began to measure and to look and, to acknowledge the fact that there are gaps in care. So a few years ago, you made the strategic decision to fully align quality, safety, and equity initiatives. Could you share how your senior leadership team and your board came to this decision? And how did you get buy-in and engagement from the entire organization?
Sure. So if I go back a little ways, we all remember the days of the Joint Conference Committee. So that was the committee of the board that dealt with issues between the medical staff, management, and the community, and sort of how do you deal with it, and the board. And we've evolved over years. And the first move for us and many others was we created a patient safety or quality and patient safety committee. And then Ebola hit. And I think it struck many of us that we can't just talk about patient safety. We need to be concerned about our employee safety. So we changed our board committee to the Quality and Safety Committee. And then a number of years ago, we began to believe and understand you can't have safety and quality if you don't have equity. And we wanted the board committee that was focused on safety and quality to be equally focused and informed about the issues around equity. And so we renamed the committee at the board level to the Quality, Safety, and Equity Committee. Well, that opens the door for the board to start asking questions about, well, what do you mean by equity? And Mindy, you sort of alluded to it. I'm not convinced that everybody believes there's an equity problem. And I'm more convinced those that do believe that it's at somebody else's institution and not their own. Mm-hmm. I had a colleague that I said one day to about 10 years ago, do you believe your CEO thinks there's a disparity of care in your ED? And he said, no, he's a white CEO. And I said to my Black colleague that was in that institution, do you believe there's disparity of care in your ED? He said, absolutely. And that was really an aha moment for me, because this was a very good, very successful, very compassionate CEO. And what I concluded from that is you don't know there's disparity of care if you're not measuring it. So our team got together and put together our 8-page quality safety dashboard that was measuring our hospital performance against each other in benchmarks in all of the safety and quality metrics that you can think of. Often told there's too many, and I would say, okay, tell me which ones to take off. They changed it and did it by aggregated group. So all of a sudden, the headlights came on, the bright lights came on of all of these safety and quality metrics that we were measuring by race, ethnicity, gender, age range, zip code, and payer. The one I share the most often, because it's one of the most obvious, is I looked down the list and it said C-section with complications. And it used to say Bryn Mawr Hospital, Paoli Hospital, Lankenau Hospital, Riddle Hospital. And they were all relatively close to one another. And some might be yellow, some might be green. But the new dashboard now says African Americans are 13.2%, whites are 7.5%. And everybody from the board, the clinicians, the doctors, Everybody was shocked to see the statistics. And what it did, when you start to put the measure in front of people, they go to work. There aren't people that work in our institutions, for the most part, that want there to be disparities of care. And so I think we made the most headway with our organization. The way we got buy-in, we started to share information that demonstrated, in fact, there is a disparity of care. And, you can talk about unconscious bias, God forbid, conscious bias, but there's a lot more to it. We recently did a study looking at TPA administration in our emergency room about a year ago. And what we found was that in one of our emergency departments, we were administering TPA in a much greater percentage in white patients than we were administering in Black patients. And that was really disturbing to me. I'm just, from you listening to me, you can know that I didn't probably react so well to that. If we had responded to the way I would have thought there was the problem, we would have done education around unconscious bias, and we would have hoped that it would fix the problem. Lo and behold, that's not what the problem was. Blacks are arriving in the emergency department at this particular hospital outside the window of eligibility for TPA for lots of reasons, whether it's fear, lack of trust, transportation, worried about the expenses. And so they show up late in their stroke process, not able to get this life-saving, drug. And so when you start to measure it and you have conversations around these very tough subjects, that's when you start to really get committed to this work.
Well, we all know that what you measure is what changes. And we in healthcare are lifelong learners, but we're also competitive. And we don't like to see that wherever unit we're in, that somebody else is outperforming. And so I think that does change the lens through which we view the issues. Let's talk a little bit about the structure that you've put into place to drive improvements. I was particularly interested in these multidisciplinary clinical environment work groups. How do they function within the organization? Who do they report to? And how is their work communicated to the board?
It's a great question. So we were blessed with a terrific chief medical officer who we lost pre-COVID, but to a really bizarre pulmonary disease. But Andy Norton put together these CEWs, the clinical environment work groups. And, in the past, we were trying to boil the ocean of problems sort of all over the place. But the CEWs brought together almost a dyad or a triad of leaders in probably 7 or 8 areas: ER, intensive care, medicine, OB, spine, musculoskeletal, pediatric. And it put those people that care for that patient population together in a room. So multidisciplinary, multi-geographic, could be multiple hospital representation, different levels of professionals, nurses, physicians, PAs, NPs, administrators, finance folks, and measurement, quality, safety experts. And one of the things they started doing was looking at this dashboard, our quality and safety dashboard. And so the OB women's CEW would take a look at all of the metrics related to obstetrical and women's care, and they would respond to the data and identify where there were gaps in care, and they would put action plans in place. They would talk about it. They would, and again, the closer you get the problem solving to where the patients are and where the clinicians are, the greater the likelihood that you're going to actually have the right solutions to the problems. And so these CEWs on a regular basis over the course of a year report up to the board's Quality, Safety, and Equity Committee. And I think despite the fact that that's the committee that hears about the bad events and hears about the root cause analysis and the action plans that we're taking to prevent these things from happening again, one of the highlights of the meeting, quite frankly, is the CEW report out, where an administrative leader, often a nurse, and a physician come together and present the work of the CEW for the last 12 months. Yeah. And that's where the real exciting exchange occurs and where the board gets a sense that, okay, these guys are not just talking about it, they're actually taking action.
This notion of just don't tell me, but tell me what you're going to do is, I think, critical for all boards to ask. It's one thing to have a dashboard. It's another thing to have a report out. But Don't share with me necessarily where we are, but where are we going to be? Were you able to standardize that work across the organization?
Yeah, you and I and a lot of our colleagues don't like weather reports. I know it's raining out. I know we have bad outcomes. What are we going to do about it? And so we've really conditioned these teams while they report the weather, they report the statistics. They then immediately go into these are the things we're doing. And what's really important is about 18 years ago, we consolidated all of our hospital-based quality and safety committees into a single system committee.
Mm.
So prior to doing that, you used to negotiate about, well, how are you going to do this or how are you going to do that? One hospital did it one way, one hospital did it another way. We had a near miss with the medication out of a Pyxis machine, and we learned through that investigation that we had 4 hospitals and we had 2 ways of supplying the Pyxis machines. One way would have prevented this error, the other one would not have. So we really have standardized issues around safety, quality, and equity. And, it's not negotiable. When we have an event at one institution, we don't need to have it repeat at 3 other institutions before we finally fix it. We look at the event that occurred. We look at the action plan. We involve people from other campuses than where the event occurred. And we develop a response. And that response is expected to be implemented in a standardized way across the system. And there's differences. We have teaching hospitals,
Sure.
not teaching hospitals. But we really don't allow us to not behave like a system.
Right.
When it comes to quality, safety, and equity.
Jack, we have about 5 minutes left, and I want to ask. I have a lot I want to ask you, but I particularly want to ask you, since this podcast series is all about leading for safety, what advice would you give to other C-suite health system leaders as they strive to support and lead their organization in quality and safety?
All of our colleagues, Mindy, have been on this mission, and I would argue maybe even a passion to improve safety for many years, ever since To Err Is Human came out and we finally accepted that it was probably pretty accurate. And it's been hard, and we've been hit with all kinds of challenges. Some people would argue that the safety in hospitals has not improved. I would disagree. I think we've become really good at measuring it and reporting it and not being punitive in our response, but being thoughtful. We've got to do the exact same thing for equity. And when people start to talk about patient safety with me, I stop them and say, I hope we're talking about safety and equity in the same breath. What I don't want to have happen is 10 years from now, somebody wake up and go, we got an equity problem. We have an equity problem today. We've had an equity problem for years. The Black maternal death rate should not be 2 or 3 times what it is for white people. All kinds of examples of where, based on race, ethnicity, gender orientation, age, you have a different outcome because there's a different approach to the care. And so what I think people can do the most and have the most impact on their community is, one, have a discussion at the board. Commit to investing in safety, quality, and equity. In our board, we actually talk about, in our strategic plan, under advancing the health and well-being of the communities we serve, we talk about the fact that we want to build trust, identify and eliminate disparities in care, with the understanding that structural racism has affected confidence in the healthcare system. When your board adopts a piece of language like that, there's an acknowledgement that those issues exist. And then there becomes buy-in to try and tackle those issues. The other thing I'd say, Mindy, is that there's nothing proprietary about the work any of us are doing around quality, safety, and equity. And I don't care if it's my colleague down the street or my colleague across the country, or the way I've been responded to when I reach out to a colleague across the street or a colleague across the country, asking for them to share information on how they're improving their quality, safety, and equity work. So bottom line, measure it. Create your dashboard. Make sure you're measuring it by those aggregated groups. Ask for support. The AHA has an unlimited amount of resources to help us in the quality, safety, and equity space. AHA recently put out a great tool in the Institute for Diversity and Health Equity called the Health Equity Roadmap. That's a great tool that people can use. And I would suggest every hospital should put themselves through that assessment. You're not going to get a grade from a teacher. Your grades aren't going to be shared with anybody else. It's a tool that your team can then use to move from level 1 to level 6 or level 5, whatever the levels are, in improving the care you're providing your community. And quite frankly, Mindy, you and I know that our colleagues that went into this business are interested in improving the health status of the communities we serve. And with the AHA and other organizations, the Joint Commission, the Institute for Healthcare Improvement, ACHE, there are tools that we can all draw upon. But we first have to accept there's a problem. We accepted there was a safety problem. We have to acknowledge there's an equity problem and bring the quality, safety, and equity initiatives together. And I think we can make great strides.
Well, thank you, Jack. And I know for you, this work is a passion, has been for a long time, and you have continued to share that with us today. Also, thank you for reminding us that what we do is to take the best possible care we can of all of our patients. And sometimes we can get distracted by all of the outside forces, but at the end of the day, if we can do that, in my view, at least, everything falls into place. I really appreciate you sharing Mainline Health's remarkable journey. Your commitment to safety, quality, and equity is inspiring, and it's clear that those values are part of the organizational DNA at Mainline. I encourage you to take the strategies we've discussed today, those of you listening to this podcast, and consider how they might be applied within your own organizations, whether it's expanding services, addressing critical community needs, or embedding equity into your operational framework. There are valuable lessons here for all of us. Be sure to visit the AHA's Quest for Quality webpage. As Jack said, there are a wealth of resources and multiple tools available to help support your journey for excellence in healthcare. Thank you for joining us today, and stay tuned for more episodes in our Quest for Quality podcast series. Thank you, Jack, and thank you all.
Thanks, Mindy.